I heard about Dr. DeWalls. He was quite active in experimental research for heart-lung machines and early bypass techniques. And these go back to the 50s, the mid-1950s. And he actually developed a oxygenator, a part of the heart-lung machine system that makes it easy to put oxygen in the blood. And that was commercialized, and so I knew about the work he did in that field. And I was in the Netherlands at the time, and I was quite active in the same kind of research, basically called mechanical assistance to the blood circulation. So our blood circulation is all pumped around by our heart, and when the heart fails, then people die, and instead of dying, we wanted them to have a mechanical device that could keep the circulation going. Yes, well, there is a number of devices, and the very first one that was worked with was started in the early 50s, and it's called the heart-lung machine, because it both took over the function of the heart and the lungs. And so by using that on a patient, the patient could be without those functions. They could stop the heart and stop oxygenating the lung. And then surgery could be performed. And when the surgery was successfully completed, the blood was returned to the patient, and the heart and the lungs of the patient would take over. And then, the whole thing was finished. Well, it was developed because it was noticed that in some cases, when the heart-lung machine was turned off, the patient would not restart its own functions, and then the heart would not start up, and the patient would die. So it was a very awkward situation to be in the operating room after an extensive surgery, and then the heart-lung machine was turned off, and nothing happened. So the patient actually died on the table. Very awkward and difficult situation. So many people were thinking about what could we do to keep the body alive, and hopefully the heart would recover. And so they did what is still called ECMO. That means extracorporeal oxygenation. And so the heart-lung machine was not switched off, it was just kept going. And the chest was closed and was sent to the floor with the heart-lung machine still going. And that could go for about maybe 20, 24 hours. Then so much damage was inflicted to the blood that the blood would turn into laminate. All the little organisms in the blood, the little cells, were all completely destroyed by the oxygenation process. And so then the next idea was, why don't we imitate the heart function by itself? We don't need artificial lungs, we need just the heart. And from the heart, you only need the left side. The right side of the heart is very diminutive. It's basically just a transit place. And so if you could imitate just the function of the left heart, you could keep the patient alive. You didn't have to damage the blood too much. And you could do this for a long time. And so this is how the whole left heart bypass research started up. And that goes back to the early 60s. And so I was quite active in that field, and I did experiments on dogs. Then I came to the United States to transplant this research into equipment that could be used on humans. We didn't have the material in the Netherlands for that, so I went to the laboratory of Dr. Kolf. That was in Salt Lake City, and he is the father of the artificial kidney. So he had a laboratory there at the University of Utah that was called the Research Center for Artificial Internal Organs. Not just the kidney, but then the heart was imitated, and they started to imitate the brain, or parts of the brain. So all kinds of artificial organs were designed there to take over the normal organs. And I was working on the artificial heart and on the left heart bypass. And so I was well aware of the work that Dr. DeWalls had done, and he was practicing here in Dayton. And not only that, at that time, when I talked to him, we came here in 1973, there was a laboratory connected to Kettering Hospital called Cox Heart Institute, which for many years was quite well known because they did research in hypertension there. That little institution is still there. It's a little building next to Kettering Hospital. It had a complete heart catheterization lab, just as good as in the hospital, and an operating room and animal facilities. So that attracted me a lot because I didn't want to give up all the research I was involved in Salt Lake City. So that was a very nice area for me to go into clinical practice at the same time continue the research work. And so that's what happened, and we did for about, I came in 73, until about 78. I did a lot of animal work in the Cox Heart Institute. But then the practice, the clinical practice became so demanding that I couldn't continue that work. And it was also prohibitively expensive. You know, I mean, it's really difficult to keep that research going. It was quite independent. The person who worked there for many years in hypertension, high blood pressure, was Dr. Cassidy. He was an older gentleman that you know, his work goes way back to the late 40s and the early 50s. So it was kind of a little gem that was sitting there, and nobody used it. So to me, it was a real. The facilities there were better than in Salt Lake City at the university. So it was very good. As it happened all over the world, really, heart surgeons were frustrated continuously about doing an operation and being at the end of the surgery and trying to start up the heart, and the heart wouldn't start. Especially difficult for surgeons because they know that the heart was repaired properly and it should be able to function, but it won't. And then to switch off the knob and tell the family the patient is now dead is very, very hard. You really have to have lived through that too, and to appreciate, that that's a big problem. And so it was a constant worry that every heart surgeon had, and I was well aware through all the research that we did have equipment to keep the patient alive with a pump. It was just that we didn't have the equipment so streamlined that it could be used in humans. And so then this company came by, Thoratec, and we worked closely with them, and they designed several designs of pumps that were covered on the inside. I have an example of it, so I can show that. Covered on the inside very carefully with materials that the blood wouldn't clot on it, and that it would be reliable, and that it would be usable for a long period of time. It wouldn't fail. All these things were built in. And then finally they came to us and said, well, I think we are ready for a human application. And so we said, well, great, then let's do that. And we went to our committee in Kettering Hospital that oversaw unusual new methods of treatment. And we convinced them, we gave several lectures, and we convinced them that this would be the right thing to do, and that we could really save lives this way. And they had a hard time with it, but they eventually gave in and said, okay, you can go ahead and do it. And so we did this first bypass in 1983, I think in June 1983. In the meantime, we were kept asking the FDA to approve it, and they eventually approved it that same year, 83, in November. And so then we were a little freer to apply it on patients. And we have done it ever since, and it's spread out, and now it's a very well-established, even common technique. Any heart surgeon that has difficulty with the heart-lung machine, patient won't come off. They just say, oh, give me a left heart bypass, and they put it in, and then the patient has a very high survival rate because the heart is a strong organ, and the reason that the heart won't come off the heart-lung machine, often something very subtle, you know, something in the microscopic structure of the heart muscle, or the chemicals are not just right. There's something that makes the heart fail, but it definitely has the capacity to heal and to get better. And so you do this left heart bypass for a day, 2 days. Sometimes I think they go up to a couple of weeks these days because the equipment is so much better. And then you wean the patient off, and then he's fine. And this first patient we did in June, I think June or July of '83, is still alive. So he's now 87, I think. And so that's a very gratifying thing, because without that pump, he would have died on the table. See, what happens is you do all this surgery, and then at a certain point, everything is ready for the patient to take over. And then you turn down the bypass, the flow of the heart-lung machine, and that's a gradual process. Takes about half an hour to sometimes an hour. And then the lungs are inflated again, and the heart starts up, fills up, and starts moving again. And then you switch off the machine, and the patient is on his own. But sometimes the heart just lays there and it doesn't move. And that's when these mechanical devices come into play. Now, an even more widely accepted and urgent area was the people that have heart attacks. That's what originally set me in this direction, because when I was a young intern in the university hospital in Amsterdam, I was in the surgical department, and we were responsible for all the admissions of the hospital, big university hospital. And we got a lot of heart attacks there. And I was a surgical intern, so I admitted these people, and I did the first things that needed to be done, and then I handed them over to the medical department. And so these people were, sometimes mildly in failure, sometimes in deep failure. And I talked to the medical people, said, well, we did everything we could here, and what are you going to do? And invariably they would say, just pray, because there's nothing they could do, nothing. So these people just went to the floor, and either they died or they didn't, but nothing you could do about it. There were no drugs or medications. Often they had a lot of pain from the heart attack, and they gave them morphine, and that was it. So at that time, I thought, boy, if we had some kind of a pump that could, keep the blood circulation going, I'm sure the heart could eventually take over, because we would do autopsies on these people after they died, and we look at the heart, and the heart was beautiful, except one little part was damaged. And that was the part that caused the whole heart to fail. So the principle that these hearts were savable was very clear, I think. It's just that we needed something to keep the patient alive while the heart had a chance to recover. When I did that first case in Kettering Hospital, it was a pretty simple device, and it had an enormous driving. I have pictures of it, big console that had to stand next to the patient. Now the whole thing is implantable, so people walk around with the left heart bypasses for years, and they bike on a bike, and they walk around, and they have the whole thing implanted with the mechanical part that drives the system, and also the different valves and timing mechanisms. And it used to be, like I said, a big console. So we came a long way. But it is very gratifying to see how all this has developed so well. In those days, there were many people working in the area of helping the failing blood circulation with something mechanical. And at the time that I started this bypass, it was primarily what we called the balloon counterpulsation. That was the accepted technique, and it was a very clever device. They put a balloon in the aorta, and then they would inflate it and deflate it, timed by the heart cycle. So each time the heart would eject blood into the aorta, the balloon would deflate, and so it was easier for the heart to pump blood into the aorta. And that was called counterpulsation, and invented by a Greek cardiologist. And that worked quite well, but when the heart stopped and didn't pump anymore, then it didn't do anything. So I thought that it was a very nice device to for mild cases of heart failure, but when the heart really failed, you needed a pump. Well, it was a very nice, pretty, refreshing hospital, because I was used to the giant university hospitals with big research departments, and this was nice, freestanding, crisp building, rather small, but with everything in it that you needed to do whatever you needed. 2 operating rooms. That was all there was, but it was very pleasant. The people were very nice, not like the university hospital I was used to, where the speed is tremendous and a lot of things go on. People are running around all the time. This was a real nice, quiet place to be. So I really liked it, and I liked the people there, and at the time they were just beginning to do the heart surgery. Dr. DeWalls was the one who started it up in Kettering Hospital, and there were a few other doctors in the city that gradually started to do heart surgery, primarily valve surgery. The coronary bypass surgery was only getting active in the early 70s, so 1970 is when the coronary bypass surgery started up. Before that time, it was primarily valve surgery, replacement of the aortic valve, the mitral valve, and things like that. Well, he was certainly a pioneer here in the city to start this up. There was another doctor, Dr. Denmark, not the one that is still working, but his dad, and he started work similar like that in Good Samaritan Hospital. So those were the only 2 hospitals that were starting heart surgery, and in 1973, heart surgery was something that most hospitals didn't do. It was, rather unusual, and it was considered only suitable for big university hospitals. And so it was just beginning to be acceptable to do in the smaller hospitals. So in that sense, Kettering was ahead of the crowd, I think.
Why do you think that was?
Well, I think primarily because of Dr. DeWalls, because he did heart surgery all his life, and he wanted to start it up here, and he made all the preparations, bought the right equipment, and got the personnel to run the heart-lung machine, and so he did all that, and like I said, in Good Sam they were doing a similar kind of work, and so it slowly started to develop. But I remember when I came here, when a heart surgery was planned, and the whole hospital was kind of, in standstill and looking, and everybody was whispering, because it was a big deal when a heart operation was done. And of course, that developed to the point that we did 4 or 5 surgeries a day in Kettering Hospital. Yeah. So that was quite a development. Originally, there was a big crowd. They had all kinds of people in the operating room for heart surgery. But that eventually thinned out in 2 circulating nurses, an anesthesiologist and his nurse, and the surgeon with, depending on the surgeon, some surgeon wanted another surgeon to assist, or a physician assistant could assist, and a scrub nurse. So that was, and there was a heart-lung machine operator. So there was about 7 to 8 people, depending on the surgery. When there was a routine case, then that was adequate. When special things needed to be done, or machines needed to be added to the equipment, then we got some more people. But on the average, about 7 people. The surgeon was well trained in heart surgery, and that's what he usually did, heart or lungs or blood vessels. But the rest of the personnel, the nurses, often rotated. So we would get a nurse that would do orthopedic surgery for a couple of weeks, and then she came in our room and she did our surgery for a couple of weeks. And so it certainly was adequate. We could work with it, but my opinion was that we should subspecialize heart surgery and take it out of the routine, and have nurses that did nothing but heart surgery anesthesiologists that did nothing. But so to kind of keep it a little separate from the rest of the hospital activities, and not only the operating room but also the post-op care, so that after heart surgery they didn't go right next to a prostatectomy and an orthopedic case, but that they were kind of separated and had the increased care that these patients need. And then when they came from the intensive care unit to the floor, that there they would have separate part of the hospital where everybody was specialized in heart problems. But that caused resistance, because it was financially not very attractive to do these specializations, because if there was not enough heart surgery around, then all these people were sitting around and they couldn't be used for other things. So it was an idea that was rather unusual and strange for the hospital in those days. And I've been pushing a lot for trying to set separate units aside for heart surgery, and that way we could do things more efficient, with better results, and monitor it more closely. And of course, eventually that all happened, but it took a lot of doing to get these ideas accepted. Eventually it did happen, and there's whole hospitals that do nothing but cardiology and heart surgery. The cardiology department was initially pretty simple, but now, if you look at these cath labs, they are really sophisticated equipment that took a long time to develop and to be accepted in the smaller hospitals in the periphery. And so now it's everybody agrees that you can't have cardiology, heart surgery, and orthopedic surgery and neurosurgery all mixed together. It has to be separate departments, because the stuff is so complex that you cannot mix them up anymore. But it took a long time to form that and shape that. We had very unusual opinions about how to treat the staff. We felt that they worked hard, they had very responsible work. They should be paid well, but they also should be treated with a lot of respect, and they needed some of the perks that the doctors got away with. So we tried to make life pleasant for them by taking them out on shopping sprees. Shell did that, and we took them to New York City with the People Express, $25 a trip. So that was nice and cheap, but you couldn't afford that. And we gave them some money, and we put them up in a hotel, and we took them on cruises to the Bahamas and to California. And that's unusual for doctor officers to do that. But we felt that that paid itself off, because they were very happy. It was a very close-knit group. And similarly, the patients, I think they needed more care, humane care, than they were receiving at the time. We could do a good job technically by doing our surgery and whatnot, but we wanted to have them be in touch with us, not directly but indirectly, so they could ask questions, they could talk to people that are knowledgeable about heart surgery. And so we hired special nurses that went around in the hospital and talked to the patients all day long, really, and to the families about whatever worries they had and what kind of questions they had. And then once a year, for a couple of years, we took them all to a Christmas party in La Comedia. We rented the whole La Comedia, and there they were all sitting around, and we had Santa Clauses, and we took Polaroid pictures and all that stuff. So we tried to make the patient happy on the year that they had their surgery. Eventually, it got so bad that or so big, that we had to rent La Comedia 2 days in a row, and then the next year we had to do it 3 days in a row, and that got so expensive we couldn't do it anymore. So we stopped that. But many people kept asking, when is the Christmas party? So, but we just couldn't keep that up. And then as far as the doctors are concerned, we started with just me, and then we added more, and Eventually we had 8 heart surgeons, and that was by far the biggest group in the city. But we couldn't only operate in Kettering. We had to go to the other hospitals too, otherwise there wouldn't be enough work for the surgeons. But it was good to have such a big group because they learned from each other and they cooperated and they coordinated so that all the things that were successful were repeated in all the other places too. And so I believe that it was good to have a big group. Well, it got much more sophisticated. Like I said, first of all, they were not separated. They initially insisted they go to the regular floor before and after. And the intensive care unit was shared with all kinds of other specialties. And then after we did these things for a while, the hospital started to copy them all. So they actually got a separate person to go around and socialize with the patient. So not just medical attention, but just sit down with them and talk to them and make them more comfortable. And they did, I think, a lot in making the hospital more attractive. So they definitely started to spend more money on the comfort of the patient than they did in the past. And that's just the way it grew. We also worked closely with the chaplains. When I just came in Kettering, the chaplains were kind of, the surgeons and their staff didn't want anything to do with them. They didn't want them close to the operating room. And yet, they need to know what happens to the patients. So I organized that the chaplains would come in once when they were official part of the chaplain group and look at a heart operation so they know what the patient goes through. And we always called them during surgery and told them to go talk to the patient's family and keep them informed what's happening. And we did that on a routine basis about every hour. These surgeries can last up to 8 hours. So the family sits there in the waiting room, has no idea what's happening, and that is frightening. So we sent messengers out, usually a chaplain or one of the nurses. They went to the patient in the waiting area and told them, what stage the surgery was in and what happened and what the expectations were. And that helped a lot. Well, it's kind of an automatic process. It's like self-hypnosis. For me, the time just kind of stood still. I didn't even notice how long the surgery took. And it just went on, and whenever the work was done, then we finished. And so it made little difference to me whether a surgery lasted 8 hours or 4 hours. When they lasted long, usually we could predict that because they were very difficult cases. But sometimes there were simple, straightforward, routine cases that something went wrong, and they didn't want to go off the lung machine, or a bypass didn't work properly, and then we had to redo part of the surgery. And so it was not always expected that a case could take long. But it never bothered me how long a case would take. I was very fortunate because I know some surgeons had a hard time standing and they have varicosities and all those problems. But I could easily do that. It was really our responsibility as surgeons to keep gently pushing the situation so that we became getting to a level that was nationally acceptable. And it was. We eventually were leading with our numbers, leading the state in mortality and morbidity and the length of stay and stuff like that. Kettering developed, definitely followed the developments that occurred, and there were several other newer developments that were hard to push through, not so much because of the hospital, but because of other doctors. Doctors are very conservative, and they are difficult to change. If they do something a certain way, why would you do it a different way? And so that was when we came with something new. That usually caused a lot of resistance. One of the things we did was do coronary heart surgery without using the heart lung machine. Now, the heart-lung machine is a great machine if you need it, because you can stop the lungs and the heart, and it has been developed to the point that this is rather safe. When I first started heart surgery in 1968, it was very dangerous. The heart-lung machine could blow bubbles in the patient's body, and they would instantly die. They could throw clots. They often had changes in their psyche, so a patient would change. You know, before surgery, he was maybe a real nice, friendly person. After surgery, he was real grumpy, and or he lost part of his memory. You know, there were all kinds of things that can go wrong with the heart-lung machine, because for hours, all the blood is pumped around, all kind of machinery, tubes, bubble oxygenators and whatnot, and returned to the patient at a high speed, 5 liters per minute, you know, faster than when you fill your car with gas. So the blood is just going all the time into the aorta. Now, if you look at an aorta of a patient, an older patient, there's all kind of plaque around it and stuff that hangs on the inside of the aortic wall, and so that jet stream would blow it all apart, and it would all go over the blood circulation. So, you know, using a heart-lung machine is necessary sometimes, or often, depending on what you do. If you replace a valve, the heart has to be opened and all that. But for a simple coronary bypass, you don't need a heart-lung machine, because you can do that while the heart is still beating. It's just development techniques to do that. And we were not the first in the world. They were doing that in South America, in Buenos Aires, and in Sao Paulo. Surgeons were doing it there primarily because they didn't have enough money to, you know, buy heart-lung machines and use them all the time. And this surgery was done originally way back in the 30s. It was developed in Russia, of all places, in Moscow. And they did coronary bypasses without heart-lung machine, because the heart-lung machine didn't exist. So they operated on these arteries, on the heart, while the heart was beating, and they did good work. It worked. And so when the heart-lung machine was developed, it was primarily to do valve operation, because then you have to stop that, cut it open. When it's cut open, it can't work anymore. And so everybody understood, yeah, you need a heart-lung machine. Then when the coronary bypass surgery came to the mix, they said, well, you know, let's use a heart-lung machine, because we do that every day. So why would we not use a heart-lung machine? And so it was just, you know, accepted generally that that's what you do. But if you study the complications of the heart-lung machine, it's pretty frightening. So I was well aware of that, because I did this work, you know, many years ago, and that was at the time that the heart-lung machine were real nasty, and they caused a lot of damage. So when I heard these South American surgeons do coronary bypass surgery without the heart-lung machine, I said, okay, let's see how that works. And so we hopped on a plane and went to South America, to Buenos Aires, and met these surgeons and saw them do it. And it was really pretty straightforward. So then, and we had done it ourselves on dogs during our experimental work in Cox. We couldn't afford a heart-lung machine, so we put these plastic bypasses in where the heart was beating. And so we came back in Dayton, and we started doing that, and we passed it by the Committee for Unusual Practices and all that. And it worked very well, yeah, and we were very pleased. Patients did well. We had the impression they were brighter. We used less blood. We didn't have to replace so much blood. And so we were pleased with it. And as time went on, we did studies to see whether these bypasses stayed open, and they stayed open fine. So originally I did all these cases, and then I taught some other surgeons in my group to do it. And it spread, but it was met with a lot of criticism, you know. So other surgeons would say, well, that is totally unacceptable. And we even had I think we had an editorial in the Dayton Daily by a prominent surgeon in the Cleveland Clinic that said that was not the standard of things to do. And, you know, it wasn't, because it was something entirely new. And they assumed that it couldn't be done, because they had done it all their lives with the heart-lung machine. And so it was hard to get it accepted. But from those days, and I think we did that in, one was the 92. In 92 we started doing it. And it didn't take more than 4 or 5 years, and the whole country was doing it. And of course, the Cleveland Clinic was publishing big articles how they had done 100 cases here and 100 cases there without a heart lung machine. So it was, these were exciting things to do, and I think it definitely built up the name and the prestige of Kettering Hospital. I read this article that they were doing this surgery without. Then I did research on it and found out that this is how coronary bypass surgery started. And it was, a whole series of 50, 60 patients were done many years ago, before the heart lung machine was invented. And so I thought by myself, why would I use the heart lung machine with all its possible dangers when you don't have to? And so, yeah, that's why, I think if there's a better way to do things, that you should do that. In the beginning, we did, like I said, 1 case a week was a lot, and the whole hospital was in uproar. And then it started getting more and more, and that too, when I had another case, people said, well, we can't do 2 a week, that's too much. Then 3 a week, that became really a burden. 4 a week, and so it grew, and with it, all the personnel, all the lab, and everything had to grow with it. So it was a big deal to make the numbers high. But eventually, I usually did 250 heart surgeries a year, and that's a very reasonable number to do. Nowadays, most surgeons do a little less, I think, because there's not that many cases anymore. But that was. And so I've done it for, 30 years? So that amounts to about 6,000, 7,000 open heart surgeries. And, that's a lot of people walking around that, without that, probably wouldn't have walked around much longer. And so it had a picture of the heart on it, and with the coronary arteries, and I would draw in for the patient where the bypasses would go. And so the cardiologist took that over and just changed my name to their name and used that for their patients too. So, and I like that because I think the patients really got a much better idea what was going to happen than when you just tell them, say, well, we're going to put some bypasses around the heart, and they don't know what it looks like and what is going to happen, and so it helped them a lot. And I, fortunately, haven't been in hospital often myself, but I think it's a frightening experience, even for me, to be in a hospital and to be a patient. You feel kind of isolated and just kind of thrown at the wolves' feet. And so I wanted to make this for the patient as acceptable as possible. And that was unusual because most doctors and surgeons didn't do that. And in most hospitals, that wasn't done. It was kind of a stately, heart surgery was kind of something that would draw a lot of fear and respect. And I wanted to pull it down a little bit to normal levels. I remember that some patients would be depressed, that's just in their nature. And some would say, well, I don't think I'm going to make it, doctor. I think I'm going to die. And when that happened, I told them that we had to postpone the surgery and get them to a psychiatrist, because when people think that, you can do a great job, but they really just die. And so I took these things very serious. But I tried to make it look as optimistic as possible within the limits of what was really going to happen. But when a patient was very critical and didn't have much chance to survive, I decided not to tell him, you're unlikely that you're going to survive, because why would you do that? If he survives, then he finds out for sure. And if he doesn't, he won't know about it. So I didn't want to frighten him too much either. Well, I would talk about technical details. So I would show them the map, and they got a copy of it, and a copy went in the chart. And I asked, they had the chance to ask questions, what the chances are, the mortality, the complications. And I spent that time with them, and then I left it to the nurse. We had we hired a special nurse that would then talk to the family some more, because inevitably, you know, they have more questions. But as a surgeon, you know, not many of them could afford to hire a nurse just specifically to talk to the patient and the family. But the hospital did it. The hospital now has, you know, special personnel that we know well, because one of our nurses took that job, and they just talk to patients from a social standpoint. So how do you feel? What do you think? What worries you? Things like that. And that's very important. Some patients need a lot of that, and some say, "Oh, I'm fine, bye," and they go watch TV some more. And others, you know, really want to talk for a long, long time. So we kind of solved that problem for the patient by having these nurses available, because the surgeons couldn't do that. You know, we had to go from case to case, and so we had limited time. I could give all the technology, you know, what kind of bypasses and what the risks were and how it was done and where the scar was going to be. But I didn't sit there and hold their hand and say, "Now, what do you feel about it? You know, does it make you scared?" And then they, you know, they open up and they tell you their feelings, and the family, of course, is there, and they want to get involved. And that's a part that I didn't do. And I didn't want the other surgeons to do it either, because it takes too long. You know, we made our rounds between cases, so we made them before surgery, early in the morning, and then between cases and after the cases. So we were in a rather tight schedule that things had to fit in. The minimally invasive was another reach out to do things, to rethink the routine of our operations. And so certain operations can be done without doing a massive opening of the chest. Our routine was to open the chest completely from top to bottom, spread it wide open, and then, you know, the things were done that needed to be done. But if you start thinking about it, then many surgeries don't need that much exposure. So they can be done through a smaller opening in a different part of the chest. And so we started working with that, and could change some of the surgeries to an approach where the wound was much smaller. Now, at that point, this was late, you know, in my career, and at that point, minimally invasive equipment was being developed by companies. And the Da Vinci company is an example of it, where they have robot arms that go into the patient, and then behind the screen you can operate on the patient without making big incisions. But much smaller scopes were developed, and so there's now scopes. The scope is a little tube with a lens at the top and a little instrument. And now most of the surgery on the joints is done through scopes. The hip joint. I remember when I was an intern many years ago in the University Hospital in Amsterdam. When we operated on the hip, we had a big incision all the way around the side of the leg. Big incision, you know, and a lot of blood loss, and it was just a massive operation. Now you put a little scope in the hip joint and do the same thing. And the same is true for gallbladder surgery, for gynecological surgery, urological. They are all done through small scopes. So this is all the result of trying to minimize the wound area of the surgery. And I was just there in the beginning trying to do it without all those instruments. So I had to do my surgery through a smaller hole, and it could be done, but nowadays they're much better because of all the new equipment. So that, you know, the minimal invasive surgery, I started real late, and late in my career, but right at the moment that all kinds of companies started thinking with us and make equipment so we can do it. I came to the Salt Lake City in 1968 with a special purpose to develop equipment so that I could use the left heart bypass for human application. Now, to do it in humans, we needed better tubes and better pumps. The pump that I used on the dogs was pretty rough, what we call a roller pump, and it damages blood, and so it's not suitable for humans. So we needed to have a better pump, and also better tubes to connect the pump to the heart. And the tube that I needed went through a peripheral artery, preferably the subclavian artery, the artery here under the shoulder, and we would advance it past the aortic valve into the aorta. And then we would remove blood from the heart and run to the pump and pump it back into peripheral artery. Very simple. So it sucks from the heart, from the left side of the heart. It would just go to a pump, and the pump would turn it back into an artery in the leg. And so, doing so, you could replace the function of the heart. And we did that in animals, and we put that bypass in place, and then we stopped the heart. We can do it electrically, so the heart went in ventricular fibrillation. And we kept the heart in ventricular fibrillation for 24 hours. So for 24 hours, the sheep, we use sheep for that, in Salt Lake City, would be just laying around, and after 24 hours, we would start the heart back up with an electrical shock and take the bypass out, and the sheep was fine. So we could, we proved that we could make the blood circulation go adequately without the heart being involved. But we needed these special tubes. In a sheep, you could, put any tube you wanted, but in the human beings, we needed very thin-walled, flexible catheters, so they wouldn't damage the inside of the heart. And so I went to a company there in Salt Lake City that made rocket casings for the rockets that we were sending around. And they had all kinds of developed techniques with glass fiber to make glass fiber reinforced tubes for the rockets that were real lightweight and had real thin walls. So I looked around in their factory for a while and took some things back to the lab, and I started making my own cannulas, my own catheters. And they came out quite well, but not as good as they should be. You needed really expertise of companies. But I was able to use them on a few patients, and it works well. But at a certain point, I had to abandon that research because I had to go to the clinic. Same story as here. In the meantime, the companies want to work, our industrial friends, and they made beautiful catheters. And they are just marvelous, real thin-walled, very flexible. They even have pumps in those catheters at the tip. So now they have a catheter that goes into the left side of the heart, same thing that I did from the peripheral artery, into the left side of the heart, and then there's a pump inside the heart that pumps the blood out into the aorta. And that works great. And these things, you can buy them. They're on the shelf in Kettering Hospital. And when a surgeon nowadays has a hard time coming off the lung machine, then they just say, hey, give me that device, and they put it in, and patient continues to live. Cardiologists are using it. They have it in their cath lab. So if something goes wrong, which sometimes happens, and the heart gets very failing, and then it doesn't maintain the circulation, then they put these pump in too, in the cath lab. So, it's marvelous how industry has followed up and did all this development. So we can actually use it in humans very successfully. In Dayton, Ohio, in the Kettering Hospital, has always been very cooperative. I talk a lot with the CEOs, and they always were cooperative, not entirely to my liking, as I told you before, but everybody tried hard, and it's a great hospital, and you see how they have continued to develop. They do real well.